All right, welcome to The Explainer. Today, we are putting on our detective hats and diving into a medical mystery, one that affects the tiniest of patients. We're going to follow the clues, starting with a really alarming symptom all the way to a surprisingly simple and elegant cure.
You know, every good mystery starts with a single compelling event, right? So let's get right to it. Here's the central clue that kicks off our entire investigation.
So picture this. You've got a healthy newborn, just a few weeks old, and all of a sudden they start vomiting. And I mean forcefully. We're not talking about a little bit of spit up here. No, this is dramatic, it's concerning, and it's something that definitely demands an immediate investigation.
Okay, let's really break this down because the details here are everything. The first clue is that it's projectile vomiting. It's forceful. The second, and this is super important, is that it's non-bilious. That means there's no yellow-green bile in it. Right away, that tells a doctor the blockage has to be somewhere before the small intestine, before the food gets a chance to mix with bile. And then there's the timing. It almost always starts around the third or fourth week of life, a critical piece of the puzzle.
So with those clues, what's our prime suspect? What is actually causing this? Well, the answer has a very specific and kind of long medical name.
And here it is, congenital hypertrophic pyloric stenosis. Whoa, that's a mouthful, right? Let's break it down. Congenital just means the baby's born with it. Hypertrophic means an overgrowth of muscle. And pyloric stenosis means the pylorus, which is basically the little muscular doorway from the stomach to the intestines, is narrowed. So, put it all together, the muscle at the exit of the stomach has gotten way too thick and it's blocking the exit. And get this, it's actually the most common reason a baby needs surgery for vomiting.
This image just shows it perfectly. Look at that. On the left, you've got a normal pylorus. It's a wide open channel, no problem for food to get through. But on the right, that muscle has thickened up so much that it's basically squeezing the channel shut. That flexible little gateway has turned into a solid, muscular wall.
So if we're building a profile of who gets this, a really clear pattern emerges. It's way more common in boys, especially firstborn boys. And there's another interesting link. It seems to be associated with babies who got a specific antibiotic, erythromycin, very early in life. Another key clue for our case file.
Okay, so now let's get to the physical exam. This is where a sharp doctor can act like a real detective and find some pretty solid evidence without any fancy equipment at all.
And this is one of the coolest parts of this whole story. This is a diagnosis you can literally feel with your fingertips. A doctor can gently press on the baby's belly, and in many cases, they can actually feel that thickened pyloric muscle. And the classic description? It feels just like a small, hard olive.
And it's not just what you can feel, it's what you can see. After a feeding, if you watch the baby's abdomen closely, you might see these little waves moving across their tummy from left to right. That's the stomach muscle. It's called peristalsis, working in overdrive, just trying so hard to force milk through that blocked exit.
So we've got clues we can feel, clues we can see, and then there's a really fascinating one hidden in the baby's lab work. All that vomiting just throws the body's chemistry completely out of whack. The kidneys, they try to compensate, but it leads to this really weird situation where the urine becomes acidic, even though the blood is actually alkaline. It's called paradoxical aciduria, and it's a classic textbook sign that the stomach's exit is blocked.
Okay, so the physical clues are really, really strong. But to be 100% sure, to really crack the case, we need to get a look inside.
And these days, the absolute gold standard for that is an ultrasound. It's just the perfect tool for the job. It's safe, there's no radiation, and it gives us super precise measurements that can nail the diagnosis. No question about it.
So what exactly are they looking for? Well, the radiologist is basically a detective with a ruler. First, they measure the length of that little channel, the pyloric canal. If it's longer than 16 millimeters, that's a big red flag. Next up, and this is probably the most important measurement, is the thickness of the muscle wall itself. Anything over 3 millimeters, and you've pretty much confirmed that muscle is overgrown.
And finally, they look at the total diameter of the whole pylorus. If that's bigger than 13 millimeters, well, case closed, the diagnosis is confirmed.
But before we had these amazing ultrasounds, the investigation looked totally different. Doctors had to rely on something called a barium study. And these old studies gave us some really classic, descriptive science. They honestly sound like clues straight out of an old detective novel.
First, you have the caterpillar sign. On the X-ray, the stomach is just massive. It's so dilated. And those muscle contractions we talked about seeing on the belly, they're so intense here that the whole stomach looks just like a giant caterpillar, straining to move forward.
Then there's the string sign, and this one really shows you how tight that blockage is. Just a tiny, thin little trickle of that white barium liquid can squeeze through the channel, and on the image it looks exactly like a piece of string.
And finally, the mushroom sign. This is where that big, overgrown muscle actually bulges into the next part of the intestine. It creates this indentation that looks just like the cap of a mushroom. You can see how these classic signs really painted a clear picture for doctors back in the day.
So whether it's confirmed with a modern ultrasound or one of those classic old signs, the diagnosis is in. And the good news? The path to fixing this is incredibly clear and super effective.
But here's the crucial thing. It's a two-step solution, and you absolutely cannot skip step 1. First things first, you have to stabilize the baby. That means fixing the dehydration and all that metabolic chaos caused by the vomiting. That is priority number 1 for safety. Only when the baby is stable can you move on to the definitive cure, which is surgery. And the surgery itself is honestly just so elegant. It's called a Ramstedt pylomyotomy. The surgeon makes this tiny incision and just splits the outer layer of that overgrown muscle. The inner lining is left totally untouched. This instantly releases that pressure and the channel just kind of pops open. It's a permanent fix, and believe it or not, the recovery is usually super